I'm very, very pleased to be here and to be able to introduce both Linda and Ryan to be your speakers this afternoon. So I signed up for this one for change because I was excited about change and motivating our facility to do change in the future also. So I'm excited about being here. So Ryan Springer is an executive director at the Danya Institute and also serves as the project director for the Central East Addiction Technology Training Center. That's a lot of words, but we abbreviate it with the ATTC. So it's a government-funded program providing analysis and training and enhanced behavioral health workforce throughout the 3 states and the District of Columbia. He's served on several national network groups also with distance education, recovery-oriented systems of care, and chairs the clinical supervision work group. And he also is a graduate of the Addiction Technology Transfer Center Leadership Institute. So welcome, Mr. Springer, and he holds a master's degree in public health. Along with Mr. Springer is Linda Oney. Thank you very much. She also brings 30 years of experience in collaboration with the national, state, and local agency, serves as a provider, an advocacy group, and higher education institution. She serves as the Director of Workforce Development for the Maryland Department of Health and Mental Hygiene,
I did.
and the Drug Abuse Administration. Previously, she served as the Director of Office of Education and Training, which we all know as OEDAS. She has promoted the evolution of addiction workforce through the development and revision of training standards, product development, and other various technology transfer activities. She also holds a master's in social work from the University of Maryland and has become a good friend of mine. So Linda, welcome. And Mr. Springer, welcome, Ryan.
I'm impressed by us.
I was going to say,
Go ahead.
Good evening, everybody. Ryan Springer. We actually stole Linda from Maryland, to put it bluntly. It was a great steal, too. Very proud of it.
They don't know I'm the
Well, we won't keep you guys too long this evening. It's the last session for the day, so we'll get through this pretty quickly. And Linda and I really aren't the highlight of this presentation. We have some providers here who are going to talk about their experience in the past 9 months. Over the past 9 months, there's a program that they just went through with us. And so they'll talk about the data that they've accumulated over the past 9 months and what they've done. And they're really the highlights. So Linda and I are just going to frame a few things for you, and then we'll let them get started. So of course, we're embracing change. Talked about it for the past 2 days. We've been talking about it for the past 1.5 years at least. And so we figured we'd give you a little presentation of what that actually looks like in action with these providers. So we're with the Danya Institute. We're a nonprofit 501c3, and we have the grant for the Central East ATTC, the very long name that our introducer talked about. But essentially, we provide a lot of training and TA work through a SAMHSA grant for behavioral health providers. And we do that in New Jersey, Maryland, Delaware, and Washington, D.C. That's the gist of what we do. Our mission, you can take a look at this on the handouts. Did we give out the handouts?
No.
No? Okay.
We're not
Got
for
some
this
handouts
training
here.
thing here.
So we've got all this information. You can take a look at that on the handouts. But essentially, what our expertise is around training, TA, community engagement activities, meeting planning, and product development. That's what we do essentially. And if you want to learn more about what we do, our newsletter goes out once a month. You can get all the information about new trainings, new activities we have going on, services we're offering. So you can check out our website, subscribe, and see what's going on. Now today we're talking about change, and if you go into Google and do a search on models of change, you've got almost 1 billion results that pop up. So we're going to cover all 1 billion of these results in the next 1.5 hours. Not really, we're just going to do 3. We're going to pick ours, of course, 2 others that I think most people know. NITEC's model, of course, is a well-known model, which really has been around a long time. The PDSA cycle's been around forever. The TCU, Texas Christian University Organizational Model of Change, and our ATTC Tech Transfer Model. And Linda, I think, will go through the details of the models while I hand these out.
Great, thank you.
There you go, Linda.
Oh, yeah, see, I'm so used to being behind the scenes. Well, it's, anybody, we had Wayne Simpson, I guess 5 or 6 years ago, come up and talk to us all. Did anybody see that? The Texas Christian University, they've done a lot of work around these things. And I think they were probably the precursor before anybody else got started. But basically, and they make pretty charts, I think. And this is their model of change. And you'll see that they do a lot of different things. They start with the strategic planning, and then you have the adoption and implementation process. And then you see the different phases of that. You got the training, the decision, action, and implementation. And at the bottom, you'll see that they talk about organizational readiness and functioning. And then at the very end, you see the practice improvement. Hopefully you'll see practice improvement at the end if you go through the structure. So that's their model. But there's other models as well, and they have 7 steps to that. You have to have 7 steps. You know that's a given. Because how many books have you read about how to be an effective business manager? 7 steps. It's the lucky number. So anytime if you're going to write a book about efficiency and organization, you should have 7 steps. But their 7 steps are identifying strengths and problems, analyzing problem, select the potential goals, then you explore those goals, and you examine the goals' consequences. Yeah, if we do this, what will happen? And then you choose your target, and you identify the sub-goals, and you choose action plans. And 7 has A and B in it, so because they had to have A and B, because then they would have moved away from 7. So the 7th one is after action. You have to review, and then you have to re-administer and assess. So those are fairly basic things. How many people have ever done something in their personal life where they wanted to improve themselves? Does anybody want to lose weight? Now, what were the steps that you did? They probably looked a little like that. Yeah. So that's the TCU's. And then you have NITEC's model. And what's NITEC stand for? Everybody should know this by heart. National Improvement Network. See? There you go. And they have a model, and it's around process improvement. And what's really interesting about the NITEC model is the NITEC folks come from an engineering background. They don't come from a clinical practice background. They're all engineers. So it's kind of interesting their take on it. And when they first got started in this, they were looking at improving access to treatment and maintaining people in treatment. And we're still looking at those goals, and I think we're doing a better job. But they had 4 aims, 5 principles. So they didn't hit the 7, but promising practice and learning collaborative. Those are the things that they tried to do to meet that model. And there's some key elements in the NITEC model. And these are the 5 questions that you should always start a process with. It's, what is it to be? What is it to be our customers? What are we trying to accomplish? How will we know if a change is an improvement and not just a change? How will we know if a change is an improvement, and what changes can we test that might result in an improvement? And then this is the big one that we all usually don't do very well. How can we sustain the improvement? And then these, again, they talked about, in order to do the NITEC process well, they suggest that you have at least 3 positions, and they identify them. You need your corporate sponsor. That means the person, usually it's a program director or somebody who can, has the ability to do the heavy lifting and help your program get through that. 2 is the change leader. Usually the poor change leader has a lot of responsibility to try to move that process through. And we're going to have some change leaders talk to you. And 3, the change team. And it's very important to decide who's going to be on that change team. And usually sometimes we don't do it right. Sometimes we choose the most powerful people in the office, and that might not be the right people. So those are things to consider in the NITEC model. And this, everybody to PDSA. You probably go home and think about that at night. And this, or maybe you have in real life. But the PDSA, it really sums up the NITEC model. You plan, you do, you study, and you act. And you do that in a rapid cycle. So that if you fail, you haven't spent a lot of time on it. But also, if you fail, then you can go back and look at it. And you've not invested years in a process that hasn't worked for you. You've only invested a short time, and you can go back to the drawing board and look again. And then we have a model that we at the ATTC in favor, and we'll let Brian talk. We like this one.
Well, the ATTCs, and I want to say this was probably, 2 years ago? They took a look at the various models that were out there. Like I said, you got almost a billion hits when you search Google. There are tons of different models out there. And I would say each one has a strength and its weakness, but you don't have to stick to one. So what we wanted to do was create a framework around change, what change looks like if you're introducing a new innovation. And this is what the ACC Network came up with around that. There's an article actually published on the model. If you go to our website, there's a link to the article, etc. But the idea is that there's no one almighty model. You can pick what works for you, for your provider, agency, for your clients. But what we wanted was to give that framework, that overall framework. So this is what we came up with. I'll go through it quickly. There are a lot of slides on this one. But essentially, you're going from developing some new innovation through translation, dissemination, adoption, and implementation. And it's cyclical. This is a process that continues. You don't get to the end and you're done. And of course, a big part of this is evaluation, getting some data, and letting that data drive what you do going forward. So development, creating and initially evaluating an innovation. And on your slides, you can see the little descriptions underneath. I won't go through in too much detail. But this is at the beginning stage of a new innovation where you're developing this new concept, a new innovative idea. And then translation. It's explaining the essential elements and relevance of the innovation. This is where research comes into play. And dissemination, promoting awareness of the innovation. And honestly, dissemination happens actively or passively going forward. Adoption, and I like to make the analogy here, or really the distinction, with the PDSA cycle. I think that fits nicely in the adoption phase. As the group will tell you, if they have a change that they want to implement, and you do the PDSA, you collect your data, it works or it doesn't work, you make a change and you move forward. And that really fits in the adoption phase, because what you're doing is trying on the new innovation and seeing if it works. You're not doing it for 10 years and then realizing, 10 years out, we just wasted $10 million. No, you're trying it on quickly, collecting some quick data, making a decision and moving on. And that's the adoption phase. And then implementation. And this is where you really want to incorporate the innovation into routine practice. So you've tried on a couple different innovations, you've dumped 4 of them, 1 works, you want to maintain that. So what do you need to do on a systems level, policy level, to really implement that in your agency? And training's not going to do that. You need something more long-term, more sustainable. And 4 things about implementation you didn't learn in school. Dissemination is not implementation. We use these words interchangeably sometimes, and they're not the same thing. Successful implementation of complex clinical practices take 2 to 4 years. If you really look at the research says it takes about, I've seen anywhere from 12 to 17 years for research to hit practice. That's a long time for us to wait. We've got 2 years until healthcare reform kicks in. We don't have 17 years for that to change. So what we try to do is speed that process up. And we hope this provides a tool for you to follow that path in a structured way and get there. And training alone is never enough. And of course, fidelity to evidence-based practices affect clinical outcomes or client outcomes. And diffusion, planned or spontaneous spread of innovation. Am I blocking you? Okay. And so the ATTC work specifically, we fall right at the end of development through the beginning of implementation. That's where we focus our time. And it's a multidimensional process that intentionally promotes the use of innovation. And so this change process or model that we present, this happens. This is what happens when you make some kind of a change. Our goal is to speed that up and make it happen in a shorter span of time. And to go along with the model, we also have a change book. And we don't have 7, but we have 10 steps to our change book. And literally, step by step, working with providers and agencies around how to move through a change process. So identified, and honestly, if you look across most of these models, they're all similar. They're pretty much similar as far as the steps that you take. So again, one is not the be-all and end-all, but it's what works best for you.
It would be like what, I said, if you were going to go on a diet or something. Some of these things are very practical, and you would figure that out on your own.
Absolutely. All we intend to do is give you a little workbook that gives you some specific questions you can answer to help get you there. I mean, we all struggle with change. So what we wanted to do in this specific project, and we've done this actually in the past, about 2 years ago, we had a collaborative project with NITEX, funded by OSI, Open Society Institute in Baltimore. And we worked with, I think, 5 providers at the time around a NITEX process for 3 months. And so this time around, we wanted to do the same thing, but we wanted, the focus here is sustainability. So we wanted to train some local experts in this change model who understand change, who could be coaches to the providers after the program's finished. The issue is we always come in, you do an event, we do a service, we do a training, we leave, and then what happens with sustainability? So the idea here is if you can create more local experts who can help continue that coaching, you don't have to pay us or anybody else how much money to come in and do that work. And that's the first time we've piloted that in Baltimore with this project. So who what? 6 provider programs we worked with. And the intent was to help build their capacity to respond to the behavioral health implications around ACA. So over 9 months, we raised the awareness with these participants. There were 18 participants total, around 3 from each agency. So we wanted to have an implementation project for 3 months working with NITEX. So NITEX coaches work with us. And then we also trained 3 participants as community change specialists. That's what we're calling the local experts, community change specialists, to help sustain that effort. And of course, partnered with OSI, ourselves, and NITEX were the folks involved in this. So the steps in this process, just summarize it quickly. Of course, recruitment and buy-in, which we found was a little harder than we expected.
Yeah.
Slightly.
We did a really stupid thing. We told everybody how much work it was going to be. and then we thought that would be challenging, and you all would just rush in and want to meet that challenge, and that didn't happen.
Not quite.
Not quite. But the people that did want to meet that challenge, we have them here today with us.
Absolutely. I mean, and every chance I get, I commend you guys again for being a part of this, because what you hear from them, they pretty much changed the culture, philosophy, the paradigm at their agencies around integration from just a small project. So that was phenomenal. So we had our training for the community change specialists, which involved a specific training on our model as well as the NITEX coaching model. We had a kickoff meeting, some ongoing coaching, site visits, and then these are actual 4 of the providers. There were 6 total. These are 4 who we presented today. And at this point, I'm going to ask the folks from EPIC, to come up and introduce yourselves and be good to go. All right. So EPIC is up first. And just go away. Yeah.
All right, hello. My name is Lindsay Harden. I'm from Epic Counseling Center, and Minette Mappa.
I'm also from Epic. I'm the coordinator of our smallest site, our Lansdowne location.
Yeah, and I work as a program development coordinator, and I actually was kind of the team leader, and then Minette was involved on a change team because she had a few more responsibilities outside of this project to do. Okay, so they asked us to put a 5x5 together, which was 5 slides about what we did. We added a few extra slides because we had 2 kind of separate goals. So I'm going to talk about the first goal, and then Minette's going to go into a little bit more detail. So in looking at what we wanted to do, obviously you guys know with all of this change going on, they wanted us to focus on integration with primary care, and then even with that we were like, okay, well, where do we start, at this point, and how are we going to make progress on something in 6 months? So we decided to start small. So one of our goals was to open communication and increase coordination of care with primary care physicians for insured clients who have an existing primary care physician, and those that were in need of medical treatment or had not seen a physician for like a year. So we were trying to identify risk factors for our clients coming in and how do we address those needs. So that was kind of our first goal. So we made some procedural changes related to that. Yes.
So, like Lindsay said, we wanted to kind of set ourselves up for success. So we really said we're just going to do baby steps. Because when we were first approached about the project, our director just says, okay, attend this. And Lindsay and I are like, all right, what are we getting ourselves into? And we were really, there was some anxiety. Are we going to be asked to do too much? And the first meeting was like, oh, we have to have results by like, what was it, 6 months, I think, and then 9 months. So
And somebody called me too and grilled me about this
I
project.
did. I was like, what is this going to involve?
So as you can see, just as we experienced with our clients, we also had some resistance, as with any change. So we thought, all right, let's go real, take baby steps. So we decided, let's pick the smallest office, which was our office. That was in Lansdowne, where we would try out some of these changes. And one change that's not here is we decided to involve frontline staff. So to be part of the change team so that they would really buy into the process. So we involved one front office staff and then one counselor so that, we told them what we were trying to do. And then some of the changes we made, one was just simply, for our assessment, we used the SMART TAP assessment. That already has questions about physical health, but what we found was, it was missing some questions, like one, whether or not clients had had a physical within the past year. So we found clinicians weren't consistent about were they asking that question or not. So when we tried to get a baseline data, we're like, how do we even gather a baseline data when we don't have it? So that was one thing we added. We looked at whether or not, if they mentioned that they had a health condition, we asked if they were being treated for it already or not. Something else that's missing from that assessment is just basic question, do they have a primary care doctor? So it's just a third question. And if they did, were they willing to sign? Were they willing to give us the contact information, and were they willing to sign a release for the primary care doctor? So very simple, and we, as part of our intake process, we made a standard procedure to try to get, a release form from clients for their primary care doctor. And then for those that gave us permission to contact their primary care doctor, we would fax a form letter just stating that the clients were in our program. We would just give a diagnosis, and we were requesting, information from them, just very little basic information. And then we just developed like a tracking sheet to record some of this information. So what did we find? Just for the planning took a lot of time. So we actually started collecting data after January 25th. So this was just from January 25th to like mid-April. We had 36 admissions, and we found that 20 were insured and 16 were uninsured. Right off the bat there, we thought, oh, look, we thought we had more uninsured than insured clients. So what we found was like, okay, so we have a good number of insured clients. Out of those clients, one had untreated health problems. So that seems like such a low number. Oh, only one doesn't have an untreated health problem, but really 8 of them had not seen their primary care doctor within the past year, and so they actually needed a checkup. And actually, the reason why it's not higher is because we get a lot of clients that come through the legal system who may have gotten a physical in jail, when they were in jail, or if they were coming from an inpatient setting, then they were able to have a physical there. But otherwise, many of them would not have. And 2 referrals were made to primary care doctors, and that is an area where we think, why only 2 referrals when there's this number that maybe needs to see a doctor? So that's an area where we need to improve. Out of the 36, 18 actually had primary care doctors, which is, again, a good number. And then out of those 18, 15 were willing to allow us to coordinate with these primary care doctors. Now, However, only 6 letters were sent. So why again? Why is that number so low? What we found was, sure, they had, those who had insurance had doctors assigned to them. Medical assistants, clients will have a doctor assigned to them. Many of them have no relationship with that doctor. They don't even, they're like, I don't know who that is. I've never called that doctor. I don't want that doctor. I want my old doctor. That's not part of that network. So sure, they were willing to sign a release, but didn't have the phone number, didn't really have any contact information for that doctor. So only 6, we were only able to really get in touch with 6. And out of the 6, we were actually very surprised. We had very low expectations and thought, well, our doctors are really busy. Will they even give us a time of day? 3, so 50% responded. And out of those 3, 2 actually, we got responses back within 24 hours. So we're like, oh, this is very encouraging that, you know, the response rate was quick. So what did we get out of it? Well, for one, we found that because we were focusing on physical health, then it also raised our clients' awareness about, you know, paying more attention to their primary care needs. Many of our clients, as we know, in the substance abuse and duly diagnosed population, they have a higher risk for infectious diseases and chronic conditions, as we've mentioned. So increased awareness of their own physical health care needs. They had more sensitive, our counselors also were more sensitive to the medical needs of our clients and incorporated these needs in their treatment plan goals. It also gave us opportunity to, at least, it helped us coordinate better with primary care doctors and made them more aware of maybe, you know, that clients had a problem with addiction, and so it just made them pay more attention, especially with meds that they were prescribing. And then finally, the improved process and procedures just will help us when we communicate with the FQHCs or primary care practices if we want to collaborate with them.
Okay, so that's kind of what we learned from all that. Some of the things that we're going to continue doing is to try to make this or sustain this. We're going to continue to collect data at that site, and then we're probably going to go to another site. We're probably also going to expand to do some other things, maybe after this conference take a bigger step to maybe not quite integrate, but maybe move a little bit more. So that's kind of what our second aim was too. We didn't even know what an FQHC was before we started, so we learned a lot about that, and I think we're at a point now where we're going to start developing those relationships and even taking another step and maybe going into one of the FQHCs, having people work there, which actually has come about very recently. So we just wanted to get acquainted with FQHCs, kind of introduce ourselves and all that stuff. We got a little bit held up because we thought that there was kind of some limits. We were kind of going to go a different direction basically, so we didn't do a ton of work in this area, but like I said, we're on our way there. So all we've really done in that area, in this aim, was to identify the FQHCs. We know that there are 4. We sent a letter out to one of them. I'm going to make a follow-up call probably Monday with all this new excitement and motivation I have from the conference. And hopefully we'll set up a meeting to figure out some sort of arrangement with at least that one, which is by our Lansdowne office, and maybe even the other ones in the other areas.
And Aileen was their coach throughout this.
Yeah, so that's what we did. We said that. Okay, so the impact, I know I'm almost out of time, but I won't even actually look at this, but the biggest thing that I take away from this whole this whole experience is really like, we learned a lot from the NIATEX process and, you know, setting up the change teams and going through these rapid cycles. And someone said this last night at the later training, which I feel the exact same way, that we kind of know how to make this change now. So like these other changes, although still overwhelming, we at least know it's not completely like, how do we even tackle this, you know? And now it's like, how do we tackle more than one thing at the same time? But at least we know we can set up the change teams. We've done it before, so we know kind of how to review, that we have to gather stats, all that stuff. So we just learned a lot from this whole process. So even though it was a very small change, also we had a pretty big impact overall, and it's going to kind of got the ball rolling for us. So I guess that's all.
Good.
I think we have Howard County up next.
So, hi, it's late in the afternoon, and I will try to be brief. My name is Marianne warnke, and I'm from Howard County Health Department, and I'm one of the clinical supervisors. Hi, Wayne. Las Vegas was great. You know, my story is 9 months ago, Howard County Health Department. We were just a substance abuse agency counseling center who just was doing pretty much substance abuse treatment. And we also knew a lot about mental health treatment because most of us are master's level clinicians. And we got this invitation by Danya Institute and ATTC, would you like to do this thing? It's going to be kind of time intensive, but you're going to learn a lot. And my boss said, hey, Marianne, I think you should do this. And it's going to be really great because Linda's involved and she's great and Ryan's involved and it's going to be really great. It's going to take a lot of your time, but you're going to learn a lot and it's going to be super. And I'm like, okay. So off I went. And honestly, I thought integration when I started was about integrating mental health more with substance abuse. And I can't thank Danya Institute and ATTC enough because in 9 months I feel like a baby was born. and I'm really serious because things like building a safety net in Howard County, I mean, we've just begun, but so much has happened and I'm really excited to tell you about that. We did some micro changes and I'll show you some specific little things we did, but we also have some really big changes that we've put into place. I'm just going to kind of zip through that. The way that I started off, and these were things, I really blended, and I think Ryan did a great job of talking about the little, the changes that ATTC talks about with diffusion, because I ended up mixing up the NIATEX process and the ATTC change a lot, and you'll see that in my slides because it's just all kind of mixed up when we talk about the change process. But when I met with my staff and I picked the change team, one of the big things I learned is you have to include people at the line level. And so for the first time ever, I included our main reception, which I had not done before, and that made all the difference in the world. And the micro change that we wanted to start with was something that I learned from NIATEX. So again, blending those two methods was really important. We started with an intake process when people came into our reception. Being a health department, our paperwork was huge. So when a patient would come in, and we use the word patient there because we're a health department and we have a lot of doctors, and we use the disease model instead of client. They had to sign about 10 pieces of paper, 10 different pieces of paper, and a lot of information, from TB to HIV to voter registration. And it would take them literally a half an hour to do just the paperwork when they would come in to our lobby. So just from the get-go, to do an assessment at our health department, it would take 1.5 to 4 hours to get their initial assessment. And it was a really good assessment, and it covered mental health and substance abuse, but there was no way we were going to make it to healthcare reform. So long story short, we went from 37 sheets of paper to 13 sheets of paper. Using a PDSA, Plan, Do, Study, Act, we went from, in a year, fiscal cycle, 48,000 sheets of paper to 16,000 sheets of paper. Reams of paper, 96 to 13. Paper cost time may not seem like a lot paper cost wise, But when you look at the amount of time saved per assessment, just from changing the paperwork, 30 minutes per assessment. So that's 30 minutes of patient time, 30 minutes of clinician time, big, big, big deal. We also do walk-in assessments, which was a change I had made beforehand, 3 days a week, which is really critical if you study healthcare reform and what you need to do with rapid, with having people have immediate access to treatment. But by changing this to 30 minutes, it means my clinicians can see 4 people a day instead of 3 people a day. So that's also a big deal. So in the macro, what I was looking at with a safety net was trying to figure out how to build partnerships with our federally qualified health center, which was Chase Brexton, which we did. And there's a lot of ways. What we talked about briefly was getting that executive sponsorship. And so those were some of the other things that ATTC and Danya Institute taught us how to do is how do you do that and how do you build those, get that information and build those relationships. But that's part of what we did as well. And so we also got an MOU with our local emergency room so that we have those referrals back and forth as well. And this is just things that you do by communicating and explaining how all of those things go back and forth, and it really isn't that hard to do. We also built a relationship with the Mental Health Authority, so now their director sits on our board, our director sits on their board and vice versa. I think I said that wrong, but a lot of things like that. We're moving to a new building in a year. We've built space for Mental Health Authority in our building. So we're going to be co-located in the same building, but we're probably also, we're really hoping to keep building more and more. We also have built space for possibly primary care physician, but no decisions have been made for sure about that yet. So again, just trying to think about how to build a safety net in the community and thinking about that. Some of the other ways that we've done that is we invested $75,000 into the local wellness center so that we combined the mental health and substance abuse dollars together. We put the case management dollars together so that the case management is combined with that as well. And then one of the other things, and I've already said some of this, is to just really take use of ATTC and Danya is also going to be helping us with a new motivational incentive program, and that's some of the new research. So from now on, when I get a referral from the emergency room or primary care, and a patient, because right now those warm handoffs aren't there. They can't walk across Howard County to get to me yet. So now I have a $10 gift card waiting for them when they get there. And I'll be working next week with ATTC on putting together a program and policy and procedures on how to do that. So I have the gift cards now, but I still need to put together the policies and procedures. And in order to do that right, I need the right research to go along with that. So those are the kinds of things we're doing in the future. I think the lessons I learned were stay really positive, have fun, which is hard to do at, I don't know, what is it, 4:15 or 4:30 in the afternoon, but really stay focused on what you did right. Keep a record. If you don't have a baseline of what you did, like if I didn't know where my assessment started, I couldn't tell you how much time I saved. One of the reasons I'm going to know what happens with my gift cards is because we have automated phone calls right now, so I know what my baseline is going to be on my show rate for the assessment, so I'll be able to tell you once I institute the gift cards what my show rate is after. So you've got to be able to keep, know that. One of the terms that you hear is parking lot, which is like every time I come to one of these meetings, I write down ideas and I think about them so that I always know what to do, like have some ideas for the future. You got to be able to keep everyone motivated, and I say you, but I mean we, because it's really easy with all of this talk about everything that's changing to sometimes get unmotivated. And then this is actually, I think, comes from ATTC and the change booklet, and Ryan kind of briefly went over that, but I want you to know that booklet works. And I take it out on a regular basis to kind of remind me what to do and what steps and things to follow. Because it's one of the ways that I stay motivated and keep myself organized when I get kind of lost or overwhelmed. And it's really easy to do that. And this is one of the quotes in that book. Success is not the perfection of the change plans originally drawn, but the reaching of the main outcome or goal. And I think it's really important to have a backup, because I find the more successful, if you will, that our program gets, the more I'm called out to go other places and do things. They talked about developing leadership. Part of our agreement was they were going to send me out and about. And I get sent out and about a lot now, so I'm not on site very much. So I need people back at home doing what I used to do. And so that's really important to keep developing leadership at the agency at home. So that's it for me. Thank you.
Well, I think what's really nice is, as both teams show you that, it was a little seed in it, and just making some basic changes have led to some bigger things. And it's really kind of inspiring to see these teams doing that it is for me at least, that there is actually, and they just take it and run with it. It's just amazing. Now, Wayne ran to Las Vegas.
Great job, too.
Supposedly he was at the ATOD conference.
Part of that.
Yeah.
My name is Wayne Clemens from the University of Maryland Medical System. Initially, when Linda sent out the email about this training, my supervisor suggested that I go. Little did I know that it's only going to be 3 people in the class, so you really could not sit in the back of the room and just relax. So actually, it was an opportunity to learn a lot of tools. One of the first things that we did.
We didn't teach that.
Oops, I broke it.
Hey, Ryan. There too.
Okay.
There you go.
All right. One of our project goals was really to improve authorizations. We had just moved into a new building. Basically moved off campus from the University of Maryland. So the goal was pretty much to try to improve the financial gains of the program. There actually was no background data because we never really studied how we completed authorizations in terms of getting our payment or the process at all. What we did find out, staff needed to complete the authorizations within a timely manner. So initially, we had a secretary that was sending out information, and the council's job was basically to complete it. We set up a change team with another supervisor and a counselor. We did not include the administrative staff, which we found out in the long run, which really is where the problem was created. So we had to go back and include the administrative secretary who actually does the billing. So what we found out is that she needed to give the counselors 30 days notice. And this was the most important part, because when you, in the city, most of the counselors there had 50 patients. So they needed time to even complete the authorizations. So it was very important that we monitored her. Initially, we were monitoring the counselors, and through the process, we found out that we had to monitor her. So it was very important that she gave them 30 days in advance notice to make sure to give the counselors enough time to complete the process. Within that process, we found out again that we had to add another person to the change team. And that person was the administrative staff who actually did the assessments for the patients coming in. The problem was that the counselors did not know that they had to do an initial assessment because the administrative staff did not let them know that this patient had insurance. So actually the change team grew by actually 2 people. The authorization rate, once we got the change team in place, we saw an exact change, and we saw exactly where the problems were, And one of the main goals that we found out is that it was very important that you have staff buy-in. The two people that we included were kind of offset from the counseling staff and really did not have a good relationship with them. But it found out that once we included them in the process, that they actually brought into the process because they realized how important their role was in the process. And that worked out very fine. What we found out is that 25 authorizations were requested. One died, one left AMA, 5 were late, so we had an 83% on-time rate. 16 primary adult care authorizations requested, and 100% was on time. I do think that the simple fact that these numbers are so much good, so much better, is the fact that we were monitoring the process, when in fact that we didn't monitor the process at all. We didn't pull up people and find out exactly what was going on, and the change team actually, I'm thinking, is the reason why this process improved. 7 initial authorizations were requested, and all of them were done. The important part was that administrative staff person letting the counselors know that this person was admitted with medical assistance or PAC, which enabled the counselors to do the authorizations at admissions. That was one of the things that we never did. When we went through the change process, we thought it was important to do the authorization at intake, as opposed to assigning that counselor, that patient to another counselor, and having that counselor do the authorization, which may take another 20 to 30 days. So doing the initial authorization at intake actually saved a great deal of time. We continue to fine tune the changes, and initially, when we started this process, I asked my supervisor what are the most important things that he felt that needed to be changed. And actually, what he sent it back to me, he said, well, you make the list, and sent it to me. So actually, I made the list. And he chose 3 things. He said the authorizations because it was a moneymaker, the benzodiazepine group, and change, the integration was not on the list. But through this process, integration actually became part of the list. And because we are in our own building right now, we are able to, when construction is finished, we're able to get the doctor and our psychiatrist to agree to the fact they will begin to try to see more patients medical-wise in terms of trying to take care of their medical issues as opposed to referring them to the hospital. The problem that we have with that is when we were on campus, it was easy to do that. Now that we're off campus, we must, I think it's very important that we try to capture them while they're there, because a lot of times sending them to the hospital when we're off campus, they're not going to go. So we can capture some of those medical problems right there. The impact was improved authorizations, and for me, it actually gained organizational skills. The ability to gather people around and to include them in the process and listen to what they have to say is very important. And actually, they brought into the process, and I thought that was the most important thing. They actually brought into the process, and actually they did what they expected to do, and they also held the other people accountable to what they were supposed to do. There was one individual that was not under my supervision, and the counselors were kind of hesitant to even deal with them. But when I spoke to the director, I thought it was better that we include them and let the staff provide the information to them, as opposed to having the supervisor say, look, you need to go to this meeting and do certain things. That process worked out great because it was the staff that was giving him directions and helping him along, as opposed to the supervisor telling him exactly what he had to do. Excellent. Thank you.
So we're actually missing one of our providers. She couldn't make it today, and that was actually Hopkins, the Broadway Center for Addiction. And I'll try to go through her slides and hopefully do it some justice. So the project aims develop a system of seamless, comprehensive care, increase reimbursement opportunities, reduce no-show rate, create administrative infrastructure and support an integrated care model. So some of the changes that they made, they developed a one-chart system for the entire clinic. And this was, I mean, honestly, the work that she did in 9 months I thought was pretty phenomenal. So they've got everybody working on a one chart system, so every client just has one chart. We don't have 10 charts around that they're all working with. They changed the assessment appointment schedule, developed the health suite restructuring plan with an emphasis on key staff. I think one of the things she mentioned, it might be on the list, is that they all work as a team right now. So they've got a care team for every client, and they all address every issue as a team. They've started conversations with managed care organizations to discuss reimbursement for services provided, streamlined the billing process for individual counseling sessions, and as I mentioned, developed the one-team approach to treatment review and planning, and changed communication practices to include all disciplines. And this is all in 9 months. So some results: 32% increase in billable individual counseling encounters, 36% reduction in new admissions, no-show rate, and greater collaboration among behavioral health, primary care, and substance abuse professionals, and reduction in duplicative paperwork due to one chart system. And you know, every time I listen to the folks talk, Mady and Cathy earlier today, we're talking about the continuum of integration. And it can start from as simple as having communication. And you can see some providers are working at that level, but it all has an impact, and huge impacts, as you can see from their examples. So it's not like you have to jump into integration tomorrow. We've got little time, but you can start wherever you are. So next steps, they want to continue to pursue approval for health suite restructuring plan, and I think this is a physical restructuring of their space. Continue to address systematic barriers to healthcare integration within the clinic, develop better systems for meaningful and functional outcome measurement, support routine health and behavioral health screening, revise policies and procedures, implement integration efforts as part of the annual strategic planning discussions. And you can see, if you think of the change model as we talked about it, at the implementation level, it's not just trying out something and that's it. They're changing their policies, their infrastructure, and their staffing. You know, they've got team meetings, one chart. They're talking big changes in order for this to be sustained. And I think that's pretty clear through the examples that you heard today.
And they got support at every level.
Yep. So lessons learned: integration is more likely to succeed when there is persistent internal champion for the effort. She was a champion, as she'll tell you. Integration should be encouraged at every opportunity, and buy-in from all disciplines is important. You know, one of the lessons I think that I'm hearing throughout the course of this conference as well is, coming from National Council, is that for the field, we have to work with primary care. There's no option. I think at this point, I hope everybody's heard that message. But it's not whether you should, but it's when do you start, and to what extent do you start. And I think that's pretty clear.
These are the next steps that we're thinking about. We're gonna do some additional training with the community change specialists, Marianne and Wayne. Will be in touch soon. So, and we're going to be working with the state and local governments to identify other opportunities to take this model and see if it works elsewhere within the state. We're really kind of excited about that. What we also want to do to help sustain this, we want to create a learning collaborative so that the participants in this project will have the opportunity to continue in that process and to build in other participants as well. And we're looking for new partners around this. You know, OSI has been good to us and we want to go back to them, but we're looking for other folks to join us in this project. You know, sustainability is a really important part of this project. 9 months, a lot of times, none of us usually have that much time to devote to something like this. And I think that really made a big difference here. You know, as a training director, I have provided so many classes around how to write a treatment plan. And I would hate to test anybody in this room around that, including myself, because, you know, we would teach folks in an isolated environment. You have 3 days with us and we teach you how to do a great treatment plan. Then you go back to the office and, you know, the training, you're busy, you have pressures from above, below. You just need to get it done. And unfortunately, sometimes as a result, what we taught you didn't get applied in the real world. Something like this, I think, allows that to happen because the real world, you're making changes in your real world, and that's the big piece. You all are making changes within your programs that you all want to see. And what's nice is it's organizationally backed by everyone within that system if you choose your change teams right. As Wayne indicated, you chose some change, some members originally to the change team, and they had to go back. They go, oh, well, we needed to add this person. And then again, you found you needed to add another person. But I think you learn this as you go through this process, and that's what's nice. I think you learn and build upon each one of these things that you do.
Yep. And I think for what we're doing here, again, the sustainability piece is huge. And so we intend to continue working with this group and the folks I mentioned from the previous round of doing this event. I spoke to actually, Mountain Manor was one of the groups. I spoke to Paul earlier, and Paul said, we're still using change teams every time. Every time there's a new innovation, a new issue that comes up, we create a change team and we move forward with it. And another group is doing the same thing. So, it might be a small change in the beginning, like you mentioned, but you've got a skill set now that you can utilize at every step going forward. And I think that's valuable. So we hope to continue working with you guys and hopefully have some new partners. So with that said, I'm going to take a second, hand out some forms, because if anyone, again, we're still looking for new partners, funding partners on this, but if anyone has an interest, whenever we do this the next time around, in having your organization be a part of it, we just actually fill out this form and we'll get in touch with you once we have that sorted out. And of course, you can contact Linda or I at any point in time. Our contact information is up there. You have it on your handouts. But we certainly hope to do this again, and hopefully outside of just Baltimore City, but larger in Maryland. DC has some interest as well. We're talking to our SSA down there. So you can just write your organization's name and contact information, and we'll be in touch once we have some funding to support that. But at this point, do you guys have any questions for our providers up here? Yeah.
Well, I found out that apparently I should just talk to the bosses, because my boss told me to do this, and I think it turned out okay.
Well, to clarify, she did actually ask us, is this something you'd be interested in, or do you think it'd be worthwhile? And that's why you got the call about how much time is this actually going to take?
Yeah, because, we really wanted it to be challenging, because we knew it was going to be a 9-month process, and we wanted folks who were going to stick for that time to stick with us, because that is asking a lot for folks.
It is.
So and they have come through. Some days I worried, but they all came through.
Well, I will say, it was a lot of work, but not as much as the reward was more than the work, I think, overall. And the biggest thing was that we had this constant push that okay, we have our next conference call, you have a deadline, you got to do this assignment or that assignment or whatever. So it wasn't like every day we were working on this project, but it was that constant reminder of, oh, remember we're working on this? Oh yeah, when you're in the middle of doing everything else. So that was a huge advantage, but it kept it moving faster than probably it normally would have.
And again, we were hoping to create a space that could allow that, because in your day-to-day, if no space is created for it, you just don't get a chance to do it. And that's part of what we're supposed to be doing as facilitators. I always say, I don't want to know everything. I don't claim to know everything. I leave that to Cathy and Mady and the folks who get it. My job is to pull the folks together who do get it with the providers, and let's make something happen that can help you guys. So I'm hopeful that it did work in that regard.
What's nice too is we found that some people were interested in learning about motivational interviewing a little bit more, and some folks were interested in learning about the incentives. So what we could do is we did a workshop around that. We invited everybody to that workshop. They got the opportunity to experience that workshop. And I think Marianne's group were considering this already, but that workshop was enough for her to go back and make a case about doing incentives. And she had some material there, and she could explain it to her people. And it's kind of nice. I think next week we're going to have a meeting about doing incentives out there in Howard County.
And now they have a leader who can help manage that change.
Yes, they do, and a very good leader. And what's really great is that I think people got really excited about this process, and once you're started on that process, I think it's kind of fun. Yeah.
I will just say that it has caught on crazy in Howard County, and it has taken on a life of its own in ways that I just never would have expected. And at first it was, like I said, it was something I didn't even really know or fully understand at all. And although it was not my idea at first, I can't say thank you enough, because with these tools and the new knowledge that we have, I feel like it's going to be exactly the sort of thing that has us ready now to move on with healthcare reform. So, I mean, it does, it just takes on a life of its own, and that's why when you talked about diffusion, I think that's exactly what that is.
Exactly. Well, if there are no other questions, one question?
I was just curious how you selected your project within your organization. Did you have meetings with the? Did you have meetings with how you selected your goal or your project? Did you have meetings with the staff to get feedback, or how did you? What was the first thing you did?
So I had different goals, and I had, like I said, I had big goals and I had little goals. And for the change team with the internal organization, I let my change team pick the first goal. And I picked a change team, and when I went through the process, and when they taught me how to do that, there was a line staff person from reception, there was a counselor, my office manager, myself, and one other person, and they actually picked the first, we as a group picked the first internal goal. So that was where the micro goal came from, and they picked the paperwork. And then the macro goals were goals that myself and my boss picked and worked on. And those I learned actually also from ATTC, Danya Institute, and NIATEX, which came from healthcare reform, which came from learning that I really had to get my agency on board with building MOUs, and really taught me. Every week I would get coaching from NIATEX and from Danya and ATTC, not every week. It felt like every week. It was actually once a month. But what I can't stress enough is the resources that were available to me from them, which were, and they would, in emailing, and they would ask me, well, that's great, Marianne, but what's the next step? Which is, have you done a walkthrough? Have you followed up with an MOU? Have you contacted the ER? And so then I would take that step forward to my boss and say, have you finished with Chase Brexton? Have you done that follow through? And honestly, there's a little bit of, when they talked about that change leader, and there's a little bit of nagging that goes along with that, and then he would take that to our, I hate to say I'm an egg, but I mean, he would take that to our health officer, and I think that's where that diffusion and things catch on.
Yeah.
And it was really nice because you had buy-in from your boss, and he was willing to do some of the work that needed to be done.
And I think buy-in comes from education, and I think buy-in came, I breezed over my first slide, but then when everyone talks about 2014 and if you want to be on the plane or off it, I'd rather be, on it.
Yeah.
I mean, that was kind of the larger impetus. Is like, we know 2014 is coming. 2014 is coming. There's no way around that. So what are the larger organizational leadership, goals that you have around that? And I think that set the impetus on the larger level. And then, for the change teams, we ask them to pick something small. Pick a small change that you can make. And the idea is, if you get a win, you've learned a skill, now you feel more empowered to take on something larger. Because however large the change is, you've got several different changes along the way to get there. So if you can handle one, the first thing, you just keep going. And it snowballs from there. I mean, I think you guys did a readiness assessment or something. NIATEX has a readiness assessment. So you can look at where you are in relation to the needs around integration. And from there you can pick one of those and start there. And so we'll continue that work as IEDs. Now you've got a whole series of actions and activities that you need to work on. We'll just pick one at a time and keep going.
And for us, it seemed like, okay, healthcare reform, because it was the healthcare reform initiative, readiness initiative. So we knew one of those 3 or 4 components were going to be the topic. And then they told us it was going to be integration with primary care, which probably, if we were on our own, we wouldn't have chosen that first, but it actually was very helpful. And then we were like, okay, how are we going to integrate? So then with getting all that information, we kind of kept narrowing it down to our first step, and then the other steps are kind of come along with that. But I don't know, we kind of picked the team as we were picking the goals. Like there was 3 of us out of the change team that were involved in the project. Myself, Minette, and our fiscal coordinator. And then we added 2 more, a secretary and counselor to the team. And then we worked out more of the details of it and how it was actually gonna work out. After we kind of picked the goals, the 3 of us, and then they helped with more of the input from there.
And the team doesn't have to be permanent, because once you've actually implemented it and it's something that you're using as an organization, then you need to monitor it. So you need somebody who can continue to monitor, but then you create a new change team around a new issue. So, I mean, it's not the same people who have to be involved every time, but you do need those individuals who understand the process and who can be a coach along the way.
And have some investment in
Yes.
solving that problem, whatever it is.
Yeah. But it's a very fluid process. And I think the strength of it is if you build that culture in your organization, then you've got leaders you can pick from to be on any change team based on the issue that comes up. So
Yeah, and it's way more effective when they're somebody that's doing it regularly instead of, like you said, your supervisor getting people involved. It's people that are in it every day, because we did a similar thing with changing our intake process and getting people more like immediate access. We didn't monitor it as much, but when we had an office administrator involved, it was a lot more effective.
What I told my staff and the whole bureau was by 2014, we have to be able to have a complete assessment done and the patient leave within an hour and a half, everything. UA assessment done, whether we're using SMART or anything else, because that's what you have to do with primary care. So, and we were at 4 hours sometimes. So they were like, what? Yep. I was like, yep, that's where by 2014 we have to be, so how are we going to do it? And I didn't try to solve it for them. So we just started with that, and that was within the micro process. It was a big problem to solve.
And I just tell you, look at the NIATEC stuff and look at the change book, and they both run scenarios and how to deal with them. There's a lot of information out there around change, and some really good information, and it's there to be had. And of course, we would like to help you with that process, but it's there.
any other questions? Because it is the end of the day. We want to get you guys out early.
Don't forget to fill out your evaluations, please, and I'll collect them in the back. I want to
Yeah.
thank this group for coming along and everybody staying till the end of the day.